Welcome to the Inspire and Ignite series with Safe States Alliance. Each month, we bring you a two-part series focused on innovations in injury and violence prevention. At the beginning of the month, we release a pre-recorded webinar. You can watch it at any time. Later in the month, we host a facilitated conversation for practitioners to come together and brainstorm opportunities to strengthen the field. For more information about the series this month, use the QR codes at the end of the video. Thanks for watching.
Hello, and welcome to our presentation, Beyond the Black Eye, Brain Injury Due to Intimate Partner Violence as a Public Health Issue. My name is Jill Daugherty, and I'm the Director of the Innovation Center at the National Association of State Head Injury Administrators.
Hello, everybody. I'm Peggy Reisher. I'm the Executive Director for the Brain Injury Association of Nebraska. Next slide. So we're excited to have you join us. We have an agenda here. As you can see, we're going to cover some brain injury basics, a little bit about screening for brain injury, also some universal accommodations, referrals and resources, and some suggestions on how you can incorporate this information into your work. So next slide. I'm going to start here at the top. What is a brain injury? I think oftentimes so many folks think of brain injury only as bumps, blows, jolts. The work that we do within both of our organizations is really looking at brain injury at a much broader perspective, what we call acquired brain injury. So as you can see here, it's really anything that's happened to our head essentially after we were born. However, it does not include hereditary or congenital or degenerative diseases. But things like brain tumors or an anoxic or hypoxic injury, which means the lack of oxygen to your brain for a while, infections of the brain, so like meningitis, strokes, aneurysms, ingestion of toxic substance, which could be, for example, carbon monoxide poisoning. We also include individuals who've maybe had dealt with opioid overdose, long COVID, and then again, traumatic brain injury. So traumatic brain injury is that bump, that blow, that jolt to the head. And Jill, I'm going to have you advance it one more time. And there you go. This is what a traumatic brain injury looks like. See how much our brains are jiggling around in our skulls? When that happens, that's what we call traumatic brain injury, causing for some a lot of difficulty. This is also known as a concussion or whiplash or abusive head trauma. So next slide. I want to dive a little deeper into hypoxic and anoxic injury, especially as it relates to those that we're working with who have become victims of domestic violence. With that lack of oxygen to our brain, it oftentimes that tends to hit our cell death in areas of memory. We have memory issues typically after an anoxic or a hypoxic injury, and it doesn't take long to have that cell death begins. 5 to 6 minutes of oxygen deprivation can cause huge problems. And I think when we see this happening within our domestic violence victims, it's oftentimes strangulation that they're dealing with, or for some, suicide attempts or even opioid overdose. So this impact can be just as tough, if not tougher, for folks that have maybe had the bumps, the blows, the jolts of like a traumatic brain injury. So I just wanted to make sure we hit that hard with you guys as you're thinking of working with folks in the domestic violence. Okay, next slide. So you've just heard how one can get a brain injury. This is really kind of what it looks like on the other side. After an injury, what we're looking for oftentimes are these signs and symptoms. And as you look at this list, I really want to make it sure I'm clear that not everybody has all of these issues after a brain injury. Depending upon where the injury is, you can have difficulties in a variety of these domains, but it's certainly not just a checklist that one can go off of. But in areas of cognitive, what we'll sometimes see is difficulty with speech and language. An individual might have some difficulty with receptive language, meaning it takes them longer to understand what it is that somebody said to them, as well as expressively. Maybe the person has a more difficult time expressing themselves or trying to get their thoughts across. Many folks will notice challenges with organization, attention, memory, learning. Just that ability to kind of get it done is oftentimes impaired after a brain injury. We also see on the physical side, individuals have it could be a variety of the things you see here: slowed movement, problems with coordination, headaches, balance, fatigue, vision, pain. I feel like in the work that I do, what I hear most frequently seems to be headaches and fatigue. Um, and the areas of vision, and it's with vision, it's not necessarily where they're having problems with acuity. What they might notice is that they're having difficulty with seeing double. For some, they have some neglect where they maybe don't see things on one side or the other. Some may say there's halos around things. So a vision always, it seems like it's very typical after traumatic brain injury. I think one report showed about 90% of folks after traumatic brain injury have some sort of vision difficulty. But I think oftentimes survivors don't think of themselves as having vision problems related to brain injury. Moving along the wheel here, we also see behavioral issues. Many will experience some, maybe a shorter fuse with anger management, being able to regulate their emotions becomes a little bit harder. Social skill challenges, aggression, impulsivity. On the areas of emotion, we see greater likelihood of depression, anxiety, irritability, and mood swings. So again, not everybody with a brain injury has all these things going on, but these are the things that we are really encouraging programs to look for when working with folks who've had a history of brain injury. Okay, next slide. So as you look at all those issues, what I do want to point out is if some of those issues are there because of a traumatic brain injury, or otherwise known as a concussion, is a mild brain injury. The good news is many folks get better quicker after a concussion or a more mild injury in a sense. The majority are going to get better in 3 to 4 weeks. That's the good news. The unfortunate part is we got this bad news is we've got typically anywhere from this 10 to 20% will require more time than that. And for some, when I say more time, it could be that they're still having challenges months later, years later, and for some, they fall into this being a chronic condition. And those are the ones that should be capturing our attention. I think oftentimes they're the unspoken ones. We also talk a lot about the importance of recognizing brain injury, because if you can recognize it, you can begin to manage it. And we do notice if it's not well managed, and a person goes out and tries to do things again, and they have another injury on top of that, the injury that they currently have, it oftentimes has a cumulative effect, kind of that snowball effect, rolling down the hill, just kind of picks up speed, and a person has a more difficult time ever really getting back to that baseline. All right, next slide. So I'd already kind of mentioned this, but we've within the brain injury community, the work that Jill and I are doing is talking more and more about how important it is to realize that brain injury is a chronic health condition for some, not everybody, but for some. And there is research showing that those symptoms that a person might have change, at the beginning, maybe changes over time. We will see sometimes symptoms will improve. For others, it gets a little worse. um, or it might feel like they're going along, feeling like they're fairly well recovered, and then all of a sudden something, they start noticing these symptoms kind of resurface again. And unfortunately, for a brain injury, that's not unlikely. And it's typically at times when there's a greater amount of stress, illness, or fatigue. And I think so frequently in our community, we think of brain injury as just an acute event. it's like it's happened once and it's going to be better and it's going to go away. And unfortunately, we're just really trying to make sure that people realize that, if they've had one injury and they're noticing brain injury issues along the way, it's because it's maybe not resolved itself, and to call it what it is. Okay, next slide. Uh, as you probably looked at those symptoms that I shared earlier on, there is a lot of those that you're like, well, gosh, that sounds like 12 other things that people experience, especially in the areas of behavioral health. And what we're finding is that there is a huge co-occurrence of brain injury and behavioral health conditions. We do see more and more research is showing that there's a greater likelihood, though, of suicide attempts, substance use, and mental health issues after a person has had a traumatic brain injury. So, what I know in the work that we're doing here within our association is really trying to encourage behavioral health programs to learn more about brain injury, because I think what they are typically taught just to focus on behavioral health, if they're not looking for brain injury, they might be misdiagnosing. And unfortunately, behavioral health providers are not always taught within their schooling, their education, they're not taught about brain injury. And so the importance of what Jill and I are trying to do is really make sure that people are understanding more about brain injury and how to add it to the things that they should be thinking about when working, especially with folks within these high-risk populations. Okay, next slide. Jill,
All
this
right.
is where you take over.
Yes, thanks, Peggy. That was a really nice overview. We want to dig a little bit more into the data around brain injury. Anyone can sustain a brain injury, and Peggy talked about the different kinds of brain injury earlier, but I do want to point out that most of the surveillance and data we have around brain injury is related just to traumatic brain injury. So I just want to stipulate that up front that most of the numbers you're going to be seeing are just traumatic brain injury. So I want to point out that the most common causes of TBI in the general population includes falls, motor vehicle crashes, and sports. And the prevalence of TBI in the general population has been estimated to be about 8.5%. So while everyone is at risk of TBI and it can be caused from a bunch of different reasons, some groups are at increased risk of TBI, and that's what I'm going to be talking about in the following slides. So which groups have an increased risk of sustaining a brain injury or TBI in particular? There are several. First, there are differences in brain injury risk by race or ethnicity. The fatal surveillance data that we have show that non-Hispanic American Indian and Alaska Native individuals have a significantly higher rate of traumatic brain injury related death than other groups. So you can see here on this slide that the rate of TBI related deaths among American Indian and Alaska Native individuals is significantly higher than any other group. For example, it's more than 3 times as high as for the Asian Pacific Islander group. American Indian Alaska Native children and adults also have higher rates of TBI related hospitalizations than other racial and ethnic groups. The factors that we know that contribute to this disparity include higher rates of motor vehicle crashes in this population, higher rates of substance use and suicide, as well as difficulty with accessing appropriate health care. And while it's difficult overall to get a good estimate of the prevalence of a lifetime history of traumatic brain injury among any group, we were able to get data from a study that was done in North Carolina that looked specifically at veterans. And they found that approximately a third of veterans, about 34.7%, reported having a lifetime history of traumatic brain injury compared to just under a quarter of non-veterans. So that's about 50% higher. More than 400,000 US service members were diagnosed with a traumatic brain injury between 2000 and 2019. The military conflicts from the beginning of the century until just recently dramatically increased the number of service members and veterans living with TBI. So this is another group that is disproportionately affected by brain injury. Moving on to people involved in the justice system, research that's been conducted in the United States suggests that about half, or I should say at least half, of people in correctional or detention facilities such as prisons and jails have a history of traumatic brain injury, but the exact number is unknown. Some smaller studies have shown an even greater prevalence, more than half. So this table here comes from a paper published by Durand and colleagues a couple of years ago that contains a sample of the studies they looked at that assess the prevalence of TBI among justice-involved populations. So some of the populations, the prisons that were assessed in this study reported a prevalence of TBI as high as 67 or 88%. So then we're talking about most of the people. And now we want to really dig into the reason that we're here today. So I said earlier that the most common causes of brain injury in the general population are falls and motor vehicle crashes and sports when we're talking about kids. But one under-recognized cause of brain injury, especially among women, is intimate partner violence. Intimate partner violence, or IPV, can often result from a brain injury, or can often result in a brain injury from a blow to the head, a gunshot wound, or from strangulation or suffocation. A comprehensive review that was done in 2019 reported brain injury prevalence estimates among various groups of IPV survivors. And the prevalence estimates range from about 20% among a sample of veterans who had experienced intimate partner violence, all the way up to 75% among a sample of women that were seeking services in a domestic violence shelter. Other studies have found an even higher prevalence among survivors of intimate partner violence. For example, a recent study conducted by Salim and colleagues found that among a sample of 40 survivors of IPV in New York reported a history of partner-induced brain injury within the last 60 days. So all of those survivors, 100% of those 40 women, reported a history of brain injury. But of course, the true prevalence of brain injury due to intimate partner violence is unknown. This is for a lot of different reasons. IPV survivors may be hesitant to report their experiences due to the emotional impacts of experiencing trauma. They may be dealing with some feelings of self-blame or concern that about their safety in relation to their perpetrator or their abuser if they report their experiences. So probably none of us are surprised to hear that a large majority of victims don't report their abuse to law enforcement officers. This has been a long-standing phenomenon. So if they're not reporting their abuse, they're also not reporting the injuries that they experience due to the abuse. Survivors have described a hesitancy to report to police due to a real or perceived fear of being believed that abuse happened and previous experience with being blamed for the violence. In certain cases, the perpetrators of the violence may even serve as caretakers or restrict a victim's access to medical care. Therefore, a victim may not be able to report their injuries to a doctor or nurse practitioner or physician assistant in the first place. And even when a brain injury has occurred, it can be difficult for survivors to recognize one, or even for healthcare providers to diagnose due to the various ways that brain injuries can present. And some of those ways were described by Peggy earlier. Some of the signs and symptoms can overlap with conditions that are also common among survivors, like post-traumatic stress disorder and depression. So sometimes it's hard to even determine for a healthcare provider that a brain injury has occurred. A complementary approach to getting information about brain injury among IPV survivors is through screening. So screening is for any health condition, including brain injury, consists of medical tests or assessments used to detect potential diseases or health conditions, even among individuals who are not evidencing signs or symptoms of the condition. So the primary goal of screening is for early detection and prevention of future consequences, which can allow for better treatment, management, and improved health outcomes over time. Screening for brain injury among intimate partner violence survivors is fortunately becoming more common, but just screening for a lifetime history of brain injury, in other words, asking someone if they've ever experienced a brain injury, doesn't necessarily provide information about current impairments or symptoms that they're experiencing. So Peggy and I think it's important to assess survivors for current brain injury symptoms or impairments to allow services to be provided or adjustments to be implemented. A lot of times survivors have not recognized that they have sustained a brain injury. So that experience alone can be enlightening, just learning that a brain injury has occurred and realizing that that brain injury can explain some of the symptoms or difficulties that they're having. One thing that it's important to point out is screening is not the same as diagnosis. If someone screens positive for a brain injury, especially if they're currently experiencing impairments, we always recommend that they seek professional medical care as well. With that being said, there are several methods that can be used to screen for brain injury among survivors, and I'm just going to go through a few of them pretty quickly. The first is the screening tool from The Ohio State University, commonly referred to as the OSU TBI ID. This screening tool asks individuals about any injuries they've had to their head or neck in their lifetime from various mechanisms like a car crash, falling, playing sports, or being in a fight. If the individual answers yes to any of those questions, they're then asked if they lost consciousness due to any of those injuries, for how long, and at what age that happened. The OSU TBI ID also asks if there was a time in their life that they experienced multiple repeated impacts to their head, which often happens when someone has experienced a history of abuse. The second tool we recommend is NASHA's online brain injury screening and support system, or what we often refer to as OBIS. It also uses the OSU TBI ID to screen for brain injury. And then it adds in a symptoms questionnaire for brain injury to assess brain injury symptoms and current impairments. If a person screens positive for a history of brain injury and associated impairments, OBIS provides them with tip sheets that they can use for practical compensatory strategies that can help them deal with the symptoms and impairments that they're experiencing. This is just a quick snapshot of the types of compensatory strategies that are provided to the individual in the OBIS screening system. So everything ranging from strategies for memory challenges to strategies for impulsivity and a checklist for better sleep. So it's really tailored to what a person is experiencing. The CHAT screening tool was specifically formulated for partner-inflicted brain injury. It was created by the Ohio Domestic Violence Network and uses the CHATS acronym to lead people through screening. So it's asking people if they've ever been choked, strangled, suffocated, hit or hurt in the head, whether they had altered consciousness, if they had certain signs and symptoms, or lack of access to resources, and if they considered seeing a doctor or counselor for any of the issues. So that's another great tool. And then lastly, similar to CHATS, the HELPS brain injury screening tool uses an acronym to guide the screening. The HELPS tool asks individuals if they've ever hit their head, if they were seen in the emergency department or hospital because of a head injury, if they lost consciousness or felt dazed or confused, if they experienced any of the list of problems, including things like headaches, dizziness, and cognitive issues, and then if they've had any significant sickness that may otherwise explain those symptoms. So there's a set of tools that can be used for brain injury, and like I said, they're increasingly being used with survivors of brain injury, which is really helping to identify brain injuries that have occurred and connecting people with services. So we think this is a great tool to use in the field. And Peggy, I'm going to throw it back to you.
Yeah, so referrals and resources and referrals for folks, if I could speak. Brain Injury Association of America is a great resource for you to turn to find out local supports and services in your state. Um, Jill, I'm going to have you talk about NASHA on this slide and the next slide.
Sure. So the National Association of State Head Injury Administrators supports state brain injury programs, and we're also working to develop best practices for brain injury programs and different ways that brain injury can be addressed. So one of our focus areas is with intimate partner violence. So we're currently working on determining what those best practices are for screening and referral. So we would encourage you to visit our website to see what resources we have. And also the last resource on this page is the Centers for Disease Control Traumatic Brain Injury pages. They have a lot of information about surveillance and also some guidelines for kids and adults and managing brain injury. So we would point you in that direction as well. And then, as Peggy said, NASHA has a list of local resources. So NASHA provides technical assistance to state brain injury programs, and we have a comprehensive state program directory that you can look up your state and see what services are available in there, including for survivors of intimate partner violence.
All right. So this is really our last slide before our ending one, but just we wanted to leave you with what are things that Safe States members can do? What are things that you can do within your own state agency at this point, whether you're a state agency or just another community partner, but naming brain injury in your IPV prevention, I think is a great start. It helps acknowledge that brain injury is a public health issue. And that there needs to be some prevention and violence efforts moved towards that. A second thing is just connecting with your brain injury partners. The Brain Injury Association of America, or is again a great place to start to find out if your state has an association or what that brain injury program might be. I can speak for myself as a Brain Injury Association of Nebraska. It's just, I feel like we've worked very closely with our DV programs or IPV programs to make sure that they're informed of what we can provide and how we can work together. The last one is just remove the barrier. Help identify and address the one small roadblock. And oftentimes that starts with having conversations about, can we start screening for brain injury? And if you start screening, what are some places the so what, now what? Okay, we found out that there's possible brain injury, and how do we help this individual? Making sure you're having conversations about what are good referral pathways. And I think also you can see here is just staff awareness, sharing this webinar with them, having folks learn more about brain injury. I think at the end of the day, what Jill and I are hoping you walk away from is that there's things that you can do. There are things that your organization can do to be better informed about brain injury, and that's get yourself some training. Asking, okay, is it a won't or a can't? Jill and I didn't even go into the won't versus can't conversation, but we do talk a lot about, when people are struggling after a brain injury, is it that they're, are they choosing to be defiant, or are they dealing with deficits? And so often those with brain injury are dealing more with deficits versus defiance. So keeping that in mind as you work with the folks you serve. You guys are truly, truly positioned in a great place to help bridge that IPV, injury prevention, and brain injury systems. So go to it. And thank you for taking the time to learn more about this today. And Jill and I, we've got, as you can see, our contact information here. Feel free to reach out to us if you feel like this would be a training your organization or agency would benefit from. Let us know. We're happy to talk to you too. So, Jill, any other words of wisdom?
No, just thanks for being here today. Definitely reach out with any more questions or to have another conversation.
Oh,
Thank you.